was like, can we talk about this? Can you talk with Tracy? I'm like, sure. I didn't tell her that I hadn't watched it in completion yet. I said, when do you want to?
Hello?
Hello.
Hi, this is Dr. Giordano.
Hi, thanks for joining us.
Thank you.
I'm so sorry. There is some kind of technological error on my end. My computer that we typically use in the conference room is saying check signal cable. So I had to call Jay and get this link to be able to get on through the phone, and I apologize.
No worries at all. Thank you. I really appreciate you being able to join in any way that is most convenient for you. So thank you all for being here today. Well, why don't we go ahead and get started? Let's begin with some introductions. So why don't we start with Tracy? Tracy, are you able to hear us?
I can.
Oh, thank you. Do you want to start with introducing yourself?
Sure. I'm Tracy Gillespie. I'm the Director of Nursing here at Cabin Creek Health Systems. We're located in Kanawha County, and I'm also the Certified Diabetes Educator.
Perfect. Thank you so much.
Thank you.
And Carmen, would you like to introduce yourself and anyone who's joining us?
Hi, Carmen Rexroad, a family physician at Pendleton Community Care in Franklin. And with me today is Janet Smith, the physician assistant who's working with our diabetics here.
Thank you so much. And Jennifer Boyd, would you like to introduce yourself?
Sure, I'm Jennifer Boyd, physician assistant with New River Health Center. Today I'm working at our Somersville site.
Perfect, thank you so much. And we have a username, I think it's TTB. All right, we can chat them. Oh, are you able to hear us?
Yes, this is Kelsey Briggs in Morgantown, West Virginia. We got a bunch of people from Population Health Team here with us.
Perfect, thank you so much.
Do you want me to leave it unmuted or want me to mute it?
You can go ahead and mute it if you'd like for now, and if anytime you'd like to chime in, you can just go ahead and hit the unmute button as well.
Okay.
Perfect, thank you so much. And what about, it's SSIBOLD?
Yeah, I'm Dr. Sabold from Medullary Health Center in Union, West Virginia.
Perfect, thank you so much. And Leslie?
Good afternoon, I'm Leslie. I'm one of the clinical pharmacists for a nonprofit pharmacy in Virginia.
Perfect, thank you so much. And Kyle Lawthorne? Kylie, sorry about that. Kylie, if you're unable to hear us or anything, we can go ahead and chat you, or you can chat us as well if you're having any audio issues. And finally, we have a number, it's 814-598-9359.
Endocrinologist.
Oh, I'm so sorry about that. I think I had you muted. Do you mind introducing yourself one more time? I apologize.
Sure. Yeah, sure. No problem. My name is Dr. Jennifer Giordano. I'm one of the endocrinologists here at West Virginia University in Morgantown.
Thank you so much. And we have one more number. It's 304-845-3221.
Hi, this is Julie Richardson. I'm a disease management coordinator with Population Health at WVU Medicine.
Thank you so much, Julie. And one more has joined us. It's SU00046.
You don't have to mix it up yet.
Okay. We can go ahead and chat them as well. But okay, great. Thank you all for joining us. Why don't we go ahead and get started? Jennifer, were you free anytime for your case follow-up? I can pull them up anytime you're ready.
Good. Let me just pull his chart up, and then you have my form from yesterday. Oh, wait a minute. I'm pulling up the wrong guy. Hold on.
Would you like us to pull up both cases side by side for?
That'd be fine. Yeah, that'd be fine.
Okay, perfect.
Thank you. Okay.
Share screen one. They're the very first one.
So I had presented this gentleman, we'll see in a minute. I think maybe it was back in the summer. Yeah, there he is. He's a 58-year-old white male, and one of the tricky things about him is that in spite of having experienced some pretty significant consequences from his diabetes, he really doesn't put a lot of effort into his own care of his diabetes. And that continues to be true with him. Oh, can you guys hear me?
We can hear you. Now we can't hear you. Now you're muted. Hey, Jen, now you're like permanently muted. We can't hear you.
Unmute now. How is that?
Yay, perfect.
That's good.
Okay, good. I hope that doesn't keep happening. Could you scroll to the bottom of the case that's on the left, the original case form? So we the person that can see there and privacy. Part of this makes me think about him. He, I can't remember if he spoke to, I can't remember we did. He just A1cs were always over 10. And he some prior to refused to go on Metformin. It's really unfortunate. He, at one point I took him off because something something I've changed since I've been coming to Echo is I used to just kind of freak out when people showed decline in renal function, and I would take them off their metformin.
Hey,
Well,
Jen.
he remembered. Yeah.
Can you hear me okay? All right, I just rejoined the meeting. I had to disconnect because I couldn't hear any of your presentation. So basically the first thing I heard was just you had to discontinue his metformin because of his renal function. I really apologize for the technological difficulty today, but I heard nothing prior to that. Jen? Hello?
Jen, you're muted again. Jen Boyd, sorry. We can't hear you now. I'm sorry.
Is this Caitlin?
Well, this is Caitlin, yes.
Hey, Caitlin, her voice was breaking up and then I just couldn't hear anything for the past few minutes, so I had to reconnect in.
Okay.
I'm not sure what's going on, but the connection's like horrible.
Yeah, I think we're going to see if she can call in real quick and connect that way. No worries, Jen. Other Jen. Sorry, there's so many Jens.
Oh, I feel terrible for the technological problems.
Yeah, I think it's probably just state of the world right now. Janet, did you want to say something? We can unmute you real quick up at Carmen's.
I think she's just trying to get closer to see the screen. See what he is taking. Okay, how's that?
Yes, we can hear you perfectly now. Can you hear
Good.
us?
That was, yeah, that's good. Okay, that was very strange. Okay, so
Jen, I'm sorry. I didn't hear any of the case presentation, and I don't have the form in front of me because the computer in our conference room isn't functioning. So I'm sorry, but if you could kind of start from the top for me. Sorry about that.
I will. It was kind of like a dry run because I was bumbling about with it anyway. So
This is
So I
a
got
follow-up.
58-year-old male, and then I got stop metformin due to renal function, and that's it.
Right. So let me fill in the blanks there. So I presented him back in the summer. His A1cs have always been over 10. At that time, he was taking Levemir 50 BID and some short-acting insulin, 10 units prior to meals. He does not take very good care of himself. He does not like to check his sugar. He does not follow dietary recommendations. And the part that I'm a little bit confused about in my case, and I apologize, I just tried to put this together yesterday, is I can't remember if you recommended we start Trulicity. It looks like he was on Trulicity when I presented him. And so I'm not sure, to be honest with you. His A1C has improved. His A1C is down to 8.4, I believe. If you can scroll down a little bit on the case presentation on the right-hand side. Yes, his most recent A1C, that's perfect right there, in October was 8.4. And this is terrible to say, but I can't remember what I did with him to get it from 10 to 8. It may be just that I talked to him about his insulin and got him using it more regularly, because I didn't add any medication. So in October, I bumped him up to 12 units of short-acting prior to meals. I haven't seen him back since then, so we'll see if that did anything. So what I started to say about the metformin was that I stopped his metformin too soon. Several years ago, he had a mild decrease in his renal function. And Dr. Giordano, one thing I just said is that one thing I've learned from ECHO I've learned the proper guidelines for when to stop metformin when there's decline in function. But unfortunately, yeah, right.
Yay!
But unfortunately, in the case of this gentleman, I guess he got unnerved by that. He really does not want to go back on metformin, which is unfortunate, because I think that would help him a lot at this point. And his renal function is normal now. So at any rate, that's something I know I could still work on. I can keep bumping up pre-meal insulin with him, but that's always a little dicey because he doesn't like to check his sugar. So I've talked to him a lot about hypoglycemia. He has what do you call it? The glucagon. Sorry, having a senior moment there. And I've just been having them go up very slowly, increasing by 2 units prior to meals. And so that's where we are with him. But I feel very encouraged. This is the first time his A1C has been below 9 in a couple of years. So I feel really encouraged that he's down to 8.4, and I'd like to continue to try to improve him. I don't think I've ever tried an SGLT2 inhibitor in him, and I guess at this A1C that might be something that's possible. So that's one of my questions. I can keep trying to talk him into metformin. And any other thoughts you have on that? So his current diabetes meds are Trulicity 1.5, Novolog 12 units prior to meals, Levemir 50 units BID. I tried to get a continuous glucose monitor approved for him, and I did not get it approved by his insurance. And I'm not sure about the details on that. When I was preparing the case yesterday, I made a note to try to look into that, because I think that would be really fantastic if you could get him a continuous glucose monitor so he could see what's happening. I think he's just averse to checking his sugar. But I think if he could see what's happening, he might maybe participate a little bit more in his own care. So that's kind of helter-skelter presentation. I hope you can make something of that. And if you have any questions, obviously I can answer.
Yeah, thanks, Jen. And thanks again for always like presenting. You know, we really appreciate your involvement so much in the cases that you bring. And congratulations on bringing his A1C down. It feels good, right?
Yes, I'm just so pleased. He's one of my guys.
I have a bunch of questions here. I'm just going to kind of go through. You may or may not be able to answer them, but this will kind of help direct further therapy. So has he seen a diabetic educator about diet and compliance, you know, with diet and compliance with insulin and timing of insulin and trying to match insulin to his meals? Has he done that?
That's a good question, and I will follow up. We have a diabetic educator on staff, and if he has, it's been a while, and so I can make sure that we've covered that with him because he'd probably be willing.
Yeah, so I always try to keep in the back of my head, you know, if someone is on a pretty high dose of insulin and their A1C is always greater, you know, persistently elevated, my questions are, have they ever truly been taught how to take insulin? And what is their technique? Are they taking it properly? Are they injecting into the right areas? You know, insulin is the best absorbed through the subcutaneous tissue, you know, through fat. I typically tell patients to go in the stomach and alternate like a pizza, you know, in a circular form around their belly button, use different areas because scar tissue will prevent adequate absorption, and to hold it there for 10 seconds. And it's surprising how many people, when they're put on insulin, are actually not educated on how to inject insulin properly. So I would kind of have him go through the steps of how he's doing it and then the timing and when he's taking it in relation to his meals, because, you know, short-acting insulin, he's on, you said short-acting, I'm not sure, Novolog or Humalog, but that usually begins to work within, you know, 5 minutes of injection. So we like to have that dosed pre-meal. And I tell people, you know, fork in one hand, insulin pen in the other. So you inject and then you begin eating. There are circumstances outside of that where we dose it postprandially, like gastroparesis, and if someone is having severe nausea and vomiting from, you know, chemo, there's definitely outliers to that. But, you know, bread and butter, most patients, we tell them take your insulin before meals. And so making sure that he's doing it properly is very important, because it doesn't matter if he's injecting 50 units of short-acting insulin. If he does it at the wrong time and he doesn't match it to the bolus of the carb in his food, you know, all is for naught. And it's actually dangerous. We could be creating, you know, hypoglycemia. So I always try to go back to square one when someone's on insulin. I'm seeing a new case and making sure they understand how to use it. They're getting their insulin appropriately, especially now with the high cost of insulin. I always ask if they get their insulin and if they're taking it. And I don't even word it as, you know, are you taking your insulin? I ask, do you ever miss insulin, and how many times a week is it? And, you know, I try to do it in that way so that they feel more comfortable opening up if they're not actually taking it. So those are my, you know, first questions about diabetic education, nutrition. You know, diet and exercise would be great. If he has not seen a CDE, he needs to. And then his GFR, what is his most recent GFR? You said it was normal now, right?
Yeah, let me verify that.
Okay, because I know you said previously it had been reduced, and I just wonder, okay, so that's normal. And then did he tell you, I know he's not checking his sugars, but I ask people if they're not checking them, if they're having symptoms of hypoglycemia. So sweats, shaking, especially, you know, his dose of Levemir is quite high. So I wonder, you know, if he's having any nocturnal hypoglycemia or waking up with sweats and shaking ever.
I usually ask about that, and he has not reported that.
Okay, good. Okay, and then what is his BMI?
His BMI is so high. He hasn't lost any weight with Trulicity. His BMI is 32.5.
Okay. And does he have any cardiac history?
He does. He has a stent. This guy, I'm just amazed that he he isn't more motivated to take care of himself. He's had stents. He has diabetic retinopathy and has had to have that treated with laser. He since I presented him, I think in the summer, he was hospitalized with cellulitis of his foot, and he recovered from that. But he just kind of goes along, kind of happy to eat what he's eating. So anyway.
Okay, so his BMI was 32, and how many kgs is he?
He is about 100 kgs.
Okay. All right. So when I look at an insulin dose in a type 2, in any diabetic, insulin is nice because it's a weight-based drug. So you can kind of get a ballpark of what a patient should be on. And if they're on excessive amounts, that gives you a hint that, they're on poor diet, they have non-compliance, which in this case it sounds like that's what we have. But, he's 100 kg. So if you calculate what his true weight-based requirement of insulin should be, most type 2 diabetics are on 0.5 to, 1. Very insulin-resistant patients, maybe up to 1.5 units per kg per day. So if we calculate, 100 and then you do times 0.5, his basal dose would be around 50 if we were saying 0.5 units per kg per day. So he's extremely beyond his weight-based dose of insulin.
Yeah.
So we know most likely his diet, or he could have insulin resistance. You said he had an ongoing foot issue. Insulin resistance happens for many reasons. Dental infections, ongoing abscesses, foot infection, any infection under the sun, any stressor, tons of different things. Meds cause insulin resistance. So we know he is insulin resistant for whatever reason because his weight-based dose is much lower than what he's truly getting. So then the other question I ask is, well, how can, he has a history of coronary artery disease, and how can we really optimize his coronary artery disease, because that is the #1 killer of type 2 diabetic patients. Okay, so then I look at his regimen and try to figure out how we can get him on lower doses of insulin and optimize his cardiovascular status with the orals and injectables that we talked about before. So Trulicity is a great drug. That's a GLP-1 agonist injected weekly, and that does have cardiovascular benefits. So that's a great drug. It also has weight loss benefits. So remember, those GLP drugs can cause increased satiety, increased insulin release, decreased glucagon. They have tons of great benefits. And so I recommend continuing the Trulicity. That's great for him. You brought up adding on metformin and an SGLT2. I'll go through metformin first. So all the guidelines are, the very first step is always diet and exercise and CDE. Second step, pharmacotherapy, always metformin. If a patient is not on metformin, the question is, well, why not? Every single type 2 diabetic should be on metformin, and there should be a good reason why they're not. So if he's hesitant to start metformin, I'm not sure if he maybe had GI upset, or if he's heard that, there's a common misconception in the community that metformin causes kidney disease. We've all talked about this. That is not true. Uncontrolled diabetes causes kidney disease. Uncontrolled blood pressure, those things contribute to kidney disease. And I tell patients, metformin has never been linked to kidney disease and worsening kidney disease. Now, if a patient has an underlying renal function, like GFR specifically, that's less than 30, it's not safe to use metformin at this time. And there are studies ongoing to see if we can use it less than 30, because some people do advocate for it less than 30. But currently the data says do not start it and stop it if they're already on it, if the GFR is less than 30. If the GFR is between 30 and 45, we absolutely use it just at the 50% dose. So maybe in the past, because his renal function was low, he potentially link that to the decline in his renal function, but I would revisit that with him. Metformin is a pill. It's $4 a month, has great benefits. It's weight neutral, has some weak data for cardiovascular protection. It's an amazing drug, and it will also help us reduce the total daily dose of insulin. So I would absolutely revisit metformin with him. And if it did cause GI upset or something, try the low dose, try the XR. Some metformin is better than none. So definitely revisit that. You know, he's on 12 units of his short acting a day. If you get him on metformin max dose, and then you brought up potentially the SGLT2 inhibitor, absolutely. Any patient that has cardiovascular disease, SGLT2 inhibitors have been shown to reduce the cardiovascular risk of future cardiovascular events. So absolutely start them on it. And now's the perfect time, because in the state of West Virginia, trying to get an SGLT2 covered with an A1C greater than 9%, it will always be denied. And there's a good reason for that too. It's because all the clinical trial data was done with A1Cs that were less than 9%. So now is the perfect time, because A1C was 8.4%. So it's more likely to be covered. I also don't start an SGLT2 inhibitor in patients that have that A1C more than 9%, not just because of the clinical trial data, but because it makes sense. You don't want to start somebody when their sugars are very uncontrolled, because they'll just have severe polyuria. That drug, the SGLT2 class, works by eliminating glucose in the urine. And so if your A1C and your sugars are severely uncontrolled, they're going to be going to the bathroom all day, every day, and they'll stop the drug. And so I don't add those on until later when I've controlled their sugar with insulin, which is what you've been trying to do. So I think now would be an ideal time to try to restart metformin, low dose, and bring up an SGLT2 inhibitor with him, alerting him that, you know, hey, when we start the oral medications, your blood sugars will come down as we expect, and we'll also need to adjust insulin once your blood sugars come down. So now is the time to really alert him of hypoglycemia as well, and help give him a scale of, you know, if you're having any blood sugars less than 70, that should be a never occurrence when you start your metformin or SGLT2. And so this is how we reduce your Levemir and your short-acting insulin. And I usually tell them to do that by, I kind of have a template set up, but I give them a printout of it. And I say, if your fasting in the morning is less than 70, you want to reduce your Levemir by 2 to 3 units every single day until your target is 80 to 130. That's our fasting sugar target, right? And then I give them a target if your pre-meal blood sugars, if you're always having, you know, less than 70, you drop that pre-meal by 1 to 2 units every single day until you're no longer less than 70. And our target is, you know, before meals is less than 50.
Okay,
So
great,
I always
great.
say 80 to 150. And that's how I reduce their insulin as I increase their orals.
Okay, that's very helpful. I have a question about the pre-meal insulin. So I usually counsel people to take it about 15 minutes before they eat. But what it sounds like what you're saying is it's okay if they're taking it right as they're about to eat, which might be a lot more convenient.
Yeah, I usually tell most people it's very hard to be compliant with 4 shots a day, especially if you're taking it and then waiting to eat. The only time I'm really strict about an exact timeline is when I'm dosing regular insulin or U500 insulin. The mechanics are different, and that insulin absolutely needs to be taken 30 minutes before eating.
Okay.
But shorter acting analog insulins, the guideline is within 5 to 15 minutes. And so for compliance purposes, I give people that little, you know, saying, I always say insulin pen in one hand, fork in the other, inject and then begin eating.
Okay, that's really different than what I do. So that's very helpful. I mean, I don't know if it makes a big difference if he's taking it, you know, 15 minutes instead of before instead of right as he's eating, but it might be, the difference might be in compliance, so, or inability to follow the instructions, so that's very helpful. Okay, well that is all very helpful. One other quick question about him. His triglycerides remain high and his HDL low. Let's see, I think the triglycerides were in like the 450 range. Yeah, 453.
Okay. So is he on a statin?
Yeah, he's on, let me just go back. I'm actually in the chart. Let me just pull that up. He is on atorvastatin. I only have him on 10 milligrams, and I'm not sure if he had a problem taking more than that. But he's also on gemfibrozol. So I guess one thing I could do is increase them. Would increasing the atorvastatin help?
Yeah, 100%.
Okay.
So high dose statin will decrease your triglycerides by 50%.
Okay, good. So I could just bump him up.
The data.
Okay.
Yeah, so the high triglycerides should improve as his blood sugar is controlled too, because beyond a statin, the best treatment for triglycerides is insulin.
Right.
Insulin metabolizes lipoprotein lipase, which in turn hydrolyzes and breaks down your triglycerides. So it's very common in a type 2 diabetic to see very high triglycerides and a low HDL for that reason, because they have an insulin deficit. And insulin is a treatment for hypertriglyceridemia. So as his blood sugar improves and gets controlled, his triglycerides should fall. If his triglycerides don't fall and they rise greater than 500, that carries a higher risk of pancreatitis. So I definitely would work on just seeing if a higher dose of how he tolerates the higher dose.
Yeah. He had some side effects on simvastatin, so I think the reason I started him on 10 milligrams of atorvastatin was to try to build, but I think he's been tolerating it, so maybe I could get him to work it up slowly.
And I think we've talked about this before, but there's the ACC risk calculator. Super easy to use. It's online. You just have to plug in a few data points, his age, if he smokes, what his pressures are, his LDL, his cholesterol panel, and it will tell you this patient, their blood pressure is or isn't controlled, should or should not they be on a statin, should or should not they be on an aspirin. It's a really helpful tool to be able to calculate the dose of statin as well, low, moderate, high. Most type 2 diabetics greater than 40 years old should be on a high dose statin. But that calculator really helps to figure out the dosing and, also helps with blood pressure and aspirin as well. So again, that's the ACC risk calculator. You just Google it.
Okay, great. Thanks. I have one other question, and it's not about this patient, and I decided not to put the whole case into a case, but my question is about GLP-1 agonists and these risks of medullary thyroid carcinoma and MEN tumors. If I have a patient who had a thyroidectomy for papillary thyroid cancer, is that a contraindication to the GLP-1 agonist?
No.
Oh,
nope,
good.
Certainly not. So there are many types of thyroid cancers. The most common type is called papillary, the kind that your patient has. That's the most benign case. More than 90% of patients have that. And most are cured, with a surgical resection and followed by good levothyroxine care and maintenance. The other more malicious types are, anaplastic, medullary, follicular is also more aggressive. And so I will also preface this by saying that the GLP-1 class of drugs in rodents only, this has been only studied in rodent and mice populations, had a higher incidence of medullary thyroid cancer. That has never been proven in human studies or a human population. Nonetheless, it's a risk, and a risk that a patient should know before they start a GLP-1 agonist. But the way that I screen a patient for that is I ask them, has anyone in your family had a history of a thyroidectomy, medullary thyroid cancer? I ask if they've had any thyroid nodules in their history. And of course, follow that up. If they do have nodules, then they may need an ultrasound and a biopsy to really investigate the nodules prior to proceeding with the GLP-1. But medullary thyroid cancer is incredibly rare. And so I think that withholding these drugs for a rare condition, and a condition that really has only been linked in rodent studies, it's sad because the GLP-1 class of drugs is a really significant game changer for diabetes. So long as you screen them properly, they can absolutely be on the GLP-1 class.
Okay.
But those are the questions I ask. Yeah, and thyroid nodules, thyroid disease, anybody in your family have thyroid cancer or thyroid scars on their neck, before you start.
So what about if it's that intermediate, like follicular, and they've had, they've had it, but they've had a thyroidectomy? What would you do in that case?
Yep, that's also safe. So the only linkage for the GLP drug was with medullary.
Medullary, okay, beautiful.
Yep, so
Okay,
papillary and follicular. Yeah, papillary and follicular are thyroid cell derived. Medullary thyroid cancer is a whole different type of thyroid cancer entirely. And it's, again, rare. It can be associated with MEN syndromes. If anybody in their family has had MEN, I do not use the GLP class. Or if the patient has had MEN or medullary thyroid cancer, I absolutely do not use the drug. But again, that is both MEN1 syndrome and medullary thyroid cancer are very rare. Papillary and follicular cancer, very common and okay to use the drug.
Thank you so much.
Mm-hmm. Sure.
That's everything from me.
Thank you both so much for Jen for the wonderful case and follow-up, and Jennifer for all the great recommendation and feedback as well. So I just wanted to ask everyone out there, did you all have any questions or perhaps any similar cases that you have seen and would like to bring up as well? All right. Well, if any of you guys have questions later on that you can think of, feel free to email me or Caitlin as well, and we can address them. Let me see. Okay, so Jennifer, I was going to ask you, we have your past PowerPoint on ADA guidelines, and we just wanted to see if maybe you'd want to go through that a little bit. It's totally up to you. We could pull that up for you as well if you'd like to do that.
I definitely don't mind kind of going through the PowerPoint. It's really up to all the other members. Do you guys really want to hear me read them off, or is there any other remaining questions that anybody would like to discuss? I'm happy to do whatever is the best educational opportunity for the people that are listening in.
Absolutely. Thank you so much.
Yeah. So Jen, Giordano, this is Caitlin. We have a handful of newer folks on the call who probably have not heard it before. And I know that you can't see the screen, but since this is the first one, if you want to just talk about a couple of things you want to hit to start the year out with and everything, we can definitely come over to your office for the next session and make sure everything's up and running.
Yeah. So I'll just kind of go through the PowerPoint, just kind of the pearls. I'm not going to read the slides verbatim, but I'll just kind of go through high points. And then you can send out the PowerPoint, and if there's questions, you guys can let me know. So the new ADA guidelines and standards of medical care we'll try to review. And again, also, I didn't preface this, but I'm covering for a different physician this month. So this is a last minute presentation, and I think that Dr. Shamsi was supposed to cover a different topic. So if there's any burning questions about the topics that Dr. Shamsi was supposed to cover, please let me know. But we'll go through the guidelines just so that there is some type of teaching. Okay, so over the past 10 years, patients that have had diabetes who achieve their recommended A1C, blood pressure, and cholesterol targets has increased. The mean A1C among people with diabetes overall nationally has also declined. So from 1999 to 2002, it was around 7.6, and we've declined to 7.2% as of 2007 to 2010 per the NHANES data. I think a lot of us who manage diabetes in the clinics, that's a shocking statistic because we're usually used to seeing severely uncontrolled, non-compliant patients. And, you know, in my clinic, the average A1C is 10 to 18%. I very rarely see these people that have A1Cs, you know, in the 7 to 8%, but that's a really, I'm always happy to read that statistic because there are people that do really well with type 2 diabetes and do amazing with this disease. So we have to also keep in mind the people we don't see. There are major improvements in cardiovascular outcomes and reductions in microvascular complications, basically because we're driving down the A1C. Nevertheless, almost up to 15% of patients, 50%, excuse me, of patients still don't meet the targets for blood pressure, blood sugar, cholesterol, and only 14% meet a target for all three measures while also avoiding smoking. So one of the first areas of recommendation are, they're called kind of a systematic approach, and that's basically speaking to the fact that, you know, care systems, which include physician, MP, PA, all of the nursing staff, CDEs, everybody who's involved, it should be a team-based care and a team-based approach. And I feel like that is lacking in healthcare. With shortened appointments to 15 to 20 minutes, it makes it incredibly difficult to communicate with, you know, CDE, patient, all the different providers involved. But it's so important that we all do try to communicate amongst, you know, eye doctor, podiatrist, diabetic educators, so we can have a team-based approach for each patient. Also, a really important point, one of the first chapters of the diabetes guidelines is trying to tailor treatment to a patient's social context. And that speaks to the different economic, environmental, political, and social conditions in which people live. And so in our state of West Virginia, there are many obstacles for our patients with diabetes. And, you know, some of those obstacles are obvious to us and some of them aren't. You know, in Morgantown, there's an abundance of restaurants and grocery stores, and, you know, very rarely does a person live within a mile of food. But there are many areas of West Virginia, and these are called food deserts. And in many other parts of our country and the world where people don't have access to fresh fruits and vegetables and fresh food in grocery stores. It's really sad to hear that, you know, some people exist off convenience store items or food dollar items and live off of, you know, carbohydrates or canned foods just because of a lack of access to food. And so trying to understand, you know, the social condition in which your patient lives, what their situation like is with food, what their customs are with food, what their family is used to eating, if they have money to eat even, and how if they have money to obtain their insulins, and understanding their social context is so important. I don't always say, well, are you taking your insulin or not taking your insulin? Like I had mentioned earlier, if I know someone's not taking their insulin, I'll say, well, you know, what are the obstacles and what are the barriers that you have that have created it, you know, it to make a difficult situation for you to eat right and take your medicine. And once we kind of boil it down to, okay, well, I haven't had any money to get my insulin. I've been using my sister's insulin, or I haven't had money to buy food in 2 days and I'm homeless. Those things, you know, that's not non-compliance. That's a situation where we really need to get social work involved, because all the insulin in the world is not going to help situations like that. So that is one of the most important things, and I'm glad that's one of the first chapters of the guidelines, because it's, you know, living in the state of West Virginia, we have a very rural population, and a lot of people exist on, you know, very little resources. So it's super important. There are a lot of resources to help these patients if they have a local hospital. I try to guide them to go to the Diabetic Education Center and support groups, which are often free through different hospitals. Here in Morgantown, we have them at churches. It's at the St. Mary's Church, through WVU. At Mon General, they have support groups, and they have diabetes health fairs, community events and screenings where you can get labs and screenings for an A1C to help patients as well if they can't afford to drive to you for their diabetic education or labs. Also, if you look online, the American Diabetes Association website has a lot of great resources and support groups that can help pair a patient with resources within their area. So then moving on to the classification and diagnosis of diabetes. So type 1 diabetes, that is an autoimmune-driven destruction of the pancreas, and it destroys the beta cells, which secrete insulin out of the pancreas. So they have 0 insulin. They will be on insulin lifelong, and without insulin, that could be fatal. Most people that miss their insulin or cannot obtain it go into diabetic ketoacidosis with nausea, vomiting, severe weight loss over time. Type 2 diabetes, on the other hand, is overall kind of a progressive decline in the beta cell function. They're making insulin. They typically just don't make enough insulin for what their body needs. Over time, it can become much more severe, and it may require 4 shots of insulin a day, which we see in a lot of our type 2 diabetic patients. But over time, it can get worse. I try to tell patients, you know, sometimes I see a type 2 diabetic patient who is just so great and compliant and trying to go to the gym and, you know, eat better, but yet their disease continues to spiral downward. And I tell all my patients, you know, diabetes is a progressively worsening disease. There are some things that we can do to curb it and stabilize it and even put it into remission. So, you know, bariatric or metabolic surgeries have proven that. But overall, it's a progressively worsening disease. And so the chances are that no matter what you do with diet and exercise in your environment, most likely over time, it's going to worsen. And I think that makes a lot of people feel better, because there is a pattern of, you know, when patients may be younger and busier in careers or not really taking care of themselves, and then when life settles down a little bit and they want to get everything together, they really blame themselves that their disease isn't improving. But it's much more than just diet and exercise. There are many other factors involved, and a big part of it is the natural progression of the underlying disease itself. And then moving on to gestational diabetes. This is defined in the 2nd or 3rd trimester of pregnancy that wasn't clearly overt before gestation. And there are many other types due to different types of medicines. There are steroid-induced diabetes, immune suppressants like mycophenolate, tacrolimus can cause diabetes or worsen diabetes. Some of the HIV medications can lead to diabetes. There's also types of diabetes that are called pancreaprivic diabetes, and that basically refers to any patient who has pancreas destruction that's not autoimmune. So someone that may have had chronic alcohol abuse, who has had multiple episodes of pancreatitis or maybe really high triglycerides, and they've had pancreatitis so many times that it has burned out the pancreas, and so the pancreas can't effectively secrete insulin. And that's referred to as pancreaporrheic. There's other types associated with diseases like cystic fibrosis. So there's many different types. The two types we're used to dealing with in the clinical situations, most commonly type 1 or type 2. To diagnose diabetes, there are a few different ways. Most commonly, we use the A1C. An A1C of 5.7 to 6.4 is considered pre-diabetes, and then diabetes, overt diabetes, is greater than 6.5%. You can use a fasting plasma glucose. Greater than 126 would be the diagnosis of diabetes. And then an oral glucose tolerance is typically used in females who are pregnant. We typically don't do that in the clinic setting because it's just a more laborious process. An A1C is much quicker, can be done the day the patient sees you, doesn't need to be done fasting. So once you have one abnormal result, you definitely want to confirm it with another A1C at a different time period, because certainly those things we talked about just a second ago, steroids, medications, stress, really severe stress, many things can cause the A1C to rise. And so doing another lab at a different time is important to document a formal diagnosis of diabetes. There are some situations that A1Cs are not ideal. So in patients that have had thalassemia, basically any hemoglobinopathy, sickle cell disease, if they have, valvular disease and they're hemolyzing their red blood cell, if they have end-stage kidney disease and they're getting EPO, any disease that affects your red blood cell turnover will naturally affect your A1C, because all your A1C means is the amount of glucose that attaches onto your hemoglobin. And so if your hemoglobin is rapidly turning over and changing, then your A1C will also rapidly change and will be a false indicator of what your blood sugar is really doing. So in those settings, you can use a finger stick, or the new CGM, continuous glucose monitoring therapy, is excellent, because that kind of gives you real-time trends of your blood sugar and doesn't rely on the A1C. I'll skip the trivia, in here. So increased risk for diabetes, or talking about pre-diabetes. Pre-diabetes means that you don't meet the criteria for diabetes, but your sugars are too high to be considered normal, and it should be viewed as an increased risk for cardiovascular disease and diabetes in the future. And so I try to really aggressively treat the patients who I see their A1C is trending up, because, once you're getting in the mid 5% range, that is not normal. Diet and exercise, we talked about a little bit earlier, are great initial therapies, but I don't sit on that and wait, because we are a very busy population of people. It is hard to carve out exercise, and many people struggle with dieting. It's a great struggle for everyone. So if you haven't made progress with diet and exercise, rapidly move to medication therapy. And I often give metformin early on in prediabetes, or I give Actos, which is a TZD, an insulin sensitizer, or if the patient is morbidly obese, I'll give GLP-1 agonists in pre-diabetic patients, because I am working hard to try to prevent overt diabetes. So I look at pre-diabetes as, it needs treated aggressively, just like overt diabetes does, but just in a different way. The criteria for testing for diabetes or pre-diabetes in an asymptomatic adult, you can pretty much test anyone in our population. The actual guideline through the ADA is any adult that's overweight, so that would be a BMI of greater than 25. In Asian Americans, the BMI is slightly different, so greater than 23 in Asian American populations is overweight. And then any adult that has one or more of the following. So like a family member that has diabetes, if they're a high-risk race or ethnicity, that's many. I will leave that to you guys to go through, but there are many within that ethnicity and race class. So be aware of that as well. A history of cardiovascular disease, high blood pressure, high triglycerides. We talked about that. So triglycerides more than 250, that's a good reason to check as well. Any female that has PCOS, being physically inactive, or if you see signs of insulin resistance, severe obesity or acanthosis nigricans anywhere on the body. Patients that have pre-diabetes, so anything more than 5.7 need to be tested yearly or even earlier if you clinically suspect that they'll progressively worsening. Women that have had gestational diabetes are at a much higher lifelong risk of developing diabetes, so they really need screened well as well, because gestational diabetes does not mean that they had it during pregnancy and it will resolve. It means that unfortunately it plagued their pregnancy and they are at a much higher risk in the future of developing diabetes, so they need screened well. For any other patient outside of this, the screening recommendation is 45 years or older. But as you can tell, I mean, most of our population meets these guidelines. So anybody needs an A1C is really what the ADA is telling us.
Thank you so much.
You guys.
We just have a few more minutes left. I didn't want to cut you off, but
No, I was going to end there. I'm on call myself, so I was going to end there and ask you guys if there's any other questions or anybody needs anything else before I get off the line here.
yeah, absolutely. If anyone had any questions or comments about the guidelines, feel free to ask them. You can chat us, email us as well. All right. Well, thank you both, Jennifer, so much for such a great session. We really appreciate you guys. We just had a couple announcements before we end the session. So there was a slight change in schedule for next time because of so we hope to be back on track by February for sure. But our next session will be on January 22nd, and it also will be at noon to 1. And we always love cases, so if anyone has any cases, please feel free to submit them at the link to the email. And if anyone has questions on how to submit a case, both Caitlin and I are always here to help you guys with that. And February will go on as scheduled, so please feel free to refer to the schedule and calendar that Caitlin created for all of us. Yeah, so that's everything. Keep posted on the recap email. And thank you again for everyone joining us today. We look forward to seeing you guys next time. Thanks. Bye-bye.
Thank you.